Klooster, Executive Director of Huron Hospice, and Stephanie Hartwick, Executive Director of the MacKay Centre for Seniors. Before we begin, I want to acknowledge this land we share. Gateway is located on the traditional territories of the Anishinaabe, Haudenosaunee, and neutral peoples of the Dish with One Spoon Wampum. Under Treaties 29 and 49 and a half, we acknowledge our responsibility to care for the beautiful land and the Great Lakes where we make our home. Please feel free to share your own land acknowledgement in the chat. The views and opinions of all speakers in this webinar may not reflect Gateway Centre of Excellence in Rural Health, but we believe in providing a platform for meaningful discussion. Now I'll pass it over to Dr. Erin.
Hello all. Thank you for joining us today. I'm just going to get my PowerPoint shared here. Thank you very much. All right, welcome to my my talk about a recent project I did centered on building a community coalition for life-limiting illness in Huron-Perth. I would like to start off by defining a palliative approach because this is a term that I'm going to be using throughout my presentation. When we think of palliative care, we often have a certain picture in mind. We imagine a person with cancer who has learned that chemo is no longer an option for them, or maybe an elderly person in a hospital bed taking their final breaths. In actuality, palliative care is a philosophy of care that focuses on symptom management, quality of life, and the goals of individual patients and families. A palliative approach adopts these principles early and throughout the disease trajectory from diagnosis onwards. It's about adapting the strategies to meet patients and families where they're at and embedding these principles in any care setting, like home care, hospitals, and long-term care, anytime a patient or a family has contact with the healthcare system. Most importantly, it's for anyone with a life-limiting illness. This includes people with neurological diseases like ALS. It includes people with organ failure like congestive heart failure, liver failure, kidney failure, or COPD, who will need goals of care conversations, proactive symptom management, including with medications like opioids, and who will need attention to quality of life long before they are actually dying, long before they make it to the palliative care outreach team or to a palliative care room at the hospital or to a hospice. Does this remind you of anyone you know? Maybe someone in your community. If you live in Huron and Perth counties, pardon me, a friend or neighbor almost certainly comes to mind. In this region, we are disproportionately older than the general Canadian population. Many in our communities are also living with income challenges, with 45% making less than a living wage for the region. This is in the face of rising costs of living, particularly in housing, energy, and food. Access to all services in Huron and Perth counties, with the exception of, I believe, just Stratford, relies on owning and maintaining both a car and a license. This is an expensive hurdle that requires a minimum level of functionality to maintain. While I wasn't able to get hard numbers on people living with chronic or life-limiting illness in the region, one can extrapolate that an aging population facing healthcare scarcity and socioeconomic challenges is in trouble. This is a population at high risk for unmet symptom needs, low quality of life, and unwanted ER visits and hospitalizations, sometimes with transfers to bigger cities that don't meet their goals of care. So what's the plan? During a time in my previous role at Huron Hospice, I had seen that there were so many strong champions for a palliative approach in Huron and Perth. They weren't really using that term, but that's what they were trying to do. People who were building relationships wherever they could, investing so much time trying to build new relationships and finding the most creative ways to get people the care that met them where they were at because they believed in doing this work. But so many people have been working in isolation or in small clusters that rely on individual relationships rather than organizational ones. Given a higher rate of turnover in our region, that put any new long-term initiatives at risk. Creating a research chair at Gateway gave us the opportunity to support a stronger coalition building initiative, project by project, with forward-looking evaluations from the ground up. This project has been about identifying goals for new projects, kind of the next step projects that could be independently funded through community or research grants as a vehicle to build these organizational relationships and gather data. That data could strengthen our advocacy for additional investments in the future. And in the meantime, we would still be working towards meeting people where they're at, improving quality of life and symptom management in Huron-Perth. To do that, I needed to go back and start talking to people about the kinds of projects they saw a need for and those they'd really want to do. I approached Huron Hospice and Jessica's House for some seed funding, for administrative costs, and fortunately, they saw value in the plan and graciously provided me with some funding. And with that, I got to work. Like most projects, this one really snowballed, and I spoke with far more people than I intended to. I really believe I could spend time talking to many more people, but then we would never get to work, so I stopped at 29 interviews. I started with the relationships I had built in my previous role and branched out from there. Most interviews were targeted with organizations I wanted to make sure were included. Others were recommendations from people that I interviewed. I included non-healthcare organizations like social services, as well as community organizations and clergy. I tried to get as much variety as I could in what was essentially supposed to be a small project. My interview guide focused on the following categories, which you can see on the left-hand side here: services, what services were available, what services my interviewees were hearing from patients and families they needed. Environments, asked about reflections about the healthcare system and what changes could be made out in the community as well. Collaborations, where were the existing collaborations and who did people want to collaborate with? Because those were opportunities for future grant pairings. What kind of education was offered, what kind of education was needed, and what helped with uptake for education, and also where there were opportunities for engagement. I asked people explicitly, what kind of projects would you like to see? What kind of projects would you be excited about? I know that this is going to be an off the side of the desk project for a lot of the people involved in this in the near future. I needed to make sure it was something they were passionate about that was going to help fill their cup. So, what kind of priorities and project ideas did I get? There were a number of priorities, so I am sharing some of them here. Shared patient information between organizations, being able to prepare for transfers, being able to monitor patients and respond proactively to changes, having up-to-date information about services and resources. Many people I interviewed said they didn't feel people were making best use of their own services, and they did not have up-to-date information about what was available elsewhere. Leadership education for clinicians in management roles. A lot of our management roles here are clinicians who have been promoted or who have been hired into those roles, but maybe aren't as familiar with the healthcare system, with QI, with evaluation, those kinds of skills that are able to make them strong advocates for their programs. Early identification came up broadly. For people in the healthcare system, this was a chance to intervene with symptom management and start having conversations. For interviewees in the community, a county culture of delaying care meant that they were doing damage control or losing touch with people suddenly, rather than being able to adapt services or accompany someone through their illness journey. Interviewees reported that so many of the patients and families they saw were struggling with social connection and food security, and transportation was a huge theme. This included transportation to medical appointments and to social events. And these are fairly common priorities across rural areas, but I needed to know what was really important to the people in Huron-Perth in order to plan next steps. Oops. Pardon me, that was a draft slide. So in terms of lists of projects, I divided them into short term, medium term, and long term. This is not a comprehensive list of all of the project ideas that came forward, but just to share some with you. We had talked about opportunities to have early conversations outside of the healthcare system, whether this was advanced care planning, whether this was the workshop in a box that has been put out through the waiting room revolution for the Hope for the Best, Plan for the Rest program. But the idea being that these conversations happening in community settings, or this education happening in community settings, in church basements, at the Legion, having a beer, not necessarily happening in a doctor's office. What people will need after they die brochure. There are a lot of administrative steps to follow after a person has died. And it would be great if we just had a brochure that could go out to all of the different organizations in our region. People die in all spaces in the healthcare system. Many organizations currently keep lists of resources. What they don't have is a list of resources that is consistently updated, that everybody knows about, because so many people asked for a list like this. So whether that is identifying an existing list that is currently kept up to date, or whether it's and then doing a big push on spreading the word about where that list is, or whether, creating one, finding a home for one. Better rounds, more accessible rounds. There are a number of rounds that happen at different places in Huron and Perth counties, and different people attend, but maybe the people who need to be there aren't always at the table. This is something that we can do in the short term. Casting a net with events, not waiting for a referral. There are many volunteer programs I heard from, for example, who were saying, we're just not getting referrals. We have volunteers who are waiting around for someone to help. We had other programs who were saying, we do a lunch, people come in here, we're able to identify, who needs help. We try and make lunches affordable. What about bringing these programs together, bringing these volunteers from these organizations into these lunches, or putting on these lunches, and then using that as opportunities to network. Maybe there's someone there you identify as needing a visit. Maybe their neighbor is someone who needs a visit, and they're going to let you know about that. And that's an opportunity for you to reach out. And of course, volunteer drivers. I heard about many people in our county who are able to get into a car or a van. They don't need medical transport, but they're not able to drive themselves, or they don't feel safe driving themselves in the evening, for example, to get to an event to help kind of, reduce social isolation, or to get folks access to a meal. Medium-term projects, targeting that early identification. There are people who are seeing folks where an early identification could be made. Resources like community paramedicine, OneCare, some of those volunteer organizations for early identification. So many people just need light housekeeping and personal care to stay in their homes. And we don't have enough personal care, and we don't have access to very much light housekeeping at all. Expanding volunteer drivers. And SIC stands for Serious Illness Conversations. People are getting serious illness conversation trainings, but it is not necessarily being integrated into organizations in ways that people who need it are flagged for it, and then time is set aside for that serious illness conversation to then be had. So maybe having a pilot site where that systemic integration happens. Also, having a palliative care visioning day where we bring everyone together. This has been successful in other regions. I think it would be very helpful for Huron and Perth. Bring in an external facilitator, bring everyone in, talk about what we're doing, set our goals for what we're doing, collect a little bit of baseline data, and then have a pattern and have a plan to move forward. That's engaging kind of a little bit more on the system level. Long-term projects. Everyone asked for a shared EMR. And we know this is tough, but we also know it's been done. It's been done in other regions. It's been done in other communities. Are there ways we can work towards this? Are there ways we can work towards, wider access to clinical connect? Can we find some strategies there? Maybe a serious illness conversation integration between sites and programs and a passport so that information from your most recent serious illness conversation comes with you. That information gets updated when you have a new one as you move from site to site. Looking at structural support for people who are unhoused and have life-limiting illness. This is a serious gap in our community right now. And of course, building that active structured coalition for a palliative approach in Huron-Perth. How am I for time, Ava?
You got about 5 to 7 more minutes if you want to take it.
Okay, great. So some of the strengths that really stood out to me in this process, there are such strong person-to-person relationships in this region. People have really worked at making this work. There is a constantly growing knowledge base in symptom management. There is a passion for high quality care here, and there's a strong desire for collaboration. Data analysis is ongoing, but particularly at the sort of deeper level, but the process has revealed so much. Nearly everyone I spoke to was enthusiastic to be a part of this. Even though many people had agreed on a recommendation from a colleague, once I was able to explain the project to them one-on-one, they were all in. And I was taking an hour out of people's day. Sometimes if I was speaking to multiple different roles within an organization, I was taking multiple hours out of their organization's workload to do this, and they were willing to do it. I expected that I would hear a fair amount of venting about barriers, but I heard actually very little of that. People are inspired and they are ready to look forward. There are so many local champions ready to work forward and make a change. I did notice that nearly everyone I spoke to expressed some sense of isolation, that their message wasn't getting out, that they didn't know what other people were working on, what information was available, or that they shared misinformation or conflicting information about other services. This sense of isolation could spill into an emotional weight that they were also carrying. This demonstrates a need for an action-oriented collaborative network so our providers don't feel so alone in this. Everyone is carrying a caseload of people experiencing life-limiting illness, and it can feel a lot like swimming upstream. That is a tough feeling when you feel like you're alone. I personally believe that providing a supportive palliative care approach is satisfying for providers, not having to push through these conversations when a patient is in crisis, and knowing that your patient's symptoms are well managed, that their goals are being met, that they are experiencing the best quality of life they can with their illness sounds like a better way to provide care. I am hedging my words here because I don't have data on this, but I would like to. I'd like to see what this could do for recruitment, retention, and provider satisfaction in our region. I'd like to see what it can do for patient and family satisfaction as well. These are some of the next steps we will be taking. I will be producing a formal report back for all of the stakeholders who were engaged in the project. It will also be available. It will be available publicly. I'm looking to strategize future plans for collaboration So looking forward to community grants, how can these grants be used to formalize relationships between organizations that already have a good relationship and to build new relationships between organizations that want to be working together but haven't necessarily done much of that yet. Using community grant applications for smaller, achievable projects within the next year or two, integrating high quality data collection into those projects based not just on the project goals, but on future projects, and also for provincial standards, so that we have, a few years of that data when some of these provincial funding opportunities come up. Eventually, let's take on some bigger projects with grants or with research funds, with research partnerships at some universities who are working with communities that are tackling some of the same issues that we are. And then I'll do this process all over again. I'll repeat the report back on what we've been doing, and I'll sit down with folks and I'll have more conversations about what our next steps should be now. I'd like to just really thank the organizations who funded this project, Huron Hospice and Jessica's House. Much appreciated. Please feel free to reach out by email if you'd like to get in touch. My email address is also on the Gateway website, and I believe we're moving on to the next stage of our webinar. So I will share my references with you very quickly, and then I will stop my screen share.
Thanks, Erin. So we're just going to pass it over to Willy now to speak. You're muted, Willy. It's all good.
I was trying to be respectful there by having it off. Hospices tend to be beautiful places, which is a good thing. They should be. This leads, though, to a perception that hospices are for some people and not for other people. That they're for people who have resources, who can afford it. So we find ourselves, always reminding people this is part of the healthcare system. It's free. Everyone is welcome. So it takes a bit of work to ensure everyone in the community knows it's there for them. So Erin spoke about this palliative approach. Well, the palliative approach ultimately will lead at times to a person choosing the hospice. So some of the work we've done to try to really make ourselves open, accessible, available to everyone is, to provide really great care to folks who sometimes come to us from the street or close to the street. And what's really interesting is that when they come to us, sometimes that care we've provided is so great, and they've had such poor care maybe to that point, they improve and live longer. A practical thing there for someone who is living with an addiction is that we will provide alcohol as part of the care to those who are addicted so that they're not in withdrawal in their final days or weeks. We have really worked, especially with our recent expansion, to make our facility completely accessible. So everything's on one level. We have fully accessible spaces like washrooms, etc. And even, accessibility for hearing. Often people are older and have trouble with hearing, as I do. We've got a hearing system set up that can be accessed for those who need that. Constantly reaching out in the community, though, as well. Tomorrow we are hosting a lunch with a number of staff from the county who work in Ontario Works. So these are staff who are often supporting folks in the community who are often kind of at the margins, who are a little more at the edge and who need to know that they're welcome to any of our services. So we're doing that tomorrow. We have a meeting in 2 weeks with 2 staff from the Stony Point Kettle Point Reserve who are coming to us. They're going to tour. We're going to chat with them and ask them, how can we provide services in a better way to support those from the Indigenous community? So, trying to welcome those in the LGBT community, being careful at admission, for example, to really find out from everyone, who's important to you. So those are just some of the things we're doing to try to really be accessible, be open and available to everyone. And I'm going to pass it over to Stephanie for her comments.
Thank you. Yeah, the MacKay Center for Seniors is hoping to be available and accessible with our programming, our just accepting that people are here for respite in terms of emotional and mental health, like being part social, engaged, and part of the community. So we're really encouraging those to take part. We've linked with the Older Adults Associated Center to provide links to well-being, which means that it removes the financial barrier if there is one. So if people are finding a need to get involved and be part of the community and find out more about the information that we have, the resources we can share with them, then they can get a social prescription and come and take part in our programming. So we try to meet everybody where they're at, and we also try and get, if there's something that somebody wants to take part in, if there's something that they'd like to be doing to engage their mind, their whole body idea. We have food, meal programs, we have social programs, we have the regular stuff cards, but we have that ability to bring people in and everybody's welcome in our doors. So
That's great. Okay, I think that's everybody. So thank you all for presenting, and it seems like everybody's doing really meaningful work. Now we have some time set aside for questions and answers. So if anybody wants to throw questions into the question box, I will pass them along to our speakers. We already have one in there. We had a question about the electronic medical records, but we got that answered. And then the next one is just on sort of resources. So Riverside Funeral Home has a booklet on what you need to do when someone passes, and they found it very helpful when they lost their late husband. One thing that would be great to have as a resource on sort of banks and the financial information surrounding that. There are some really difficult happenings that happen without knowing the rules in advance. And so they're just wondering if there's any plans to create resources or information for widows and widowers and people who have had family members pass.
I believe that would be part of a brochure that we would put together. There was definitely uh when we talked about it, when I spoke about it with some of the interviewees, we definitely included some of that information. But thank you for highlighting that as a need. I will write down that we need to be sure to include that. And it looks like, oh, great. Thank you very much.
Correct. Thank you. Um, I'll I'll give one for Willie next. So, how might the services provided by the hospice and other equivalent organizations in the area be different than in urban areas? So, what are some of the benefits to having a hospice in a rural area?
Last month, I was at some meetings at a hospice, which was in Etobicoke. So it's a beautiful place, but they only had parking available for visitors because the limitations of their space. And so we who were at this meeting had to park in the mall parking lot across the street. The location of this hospice was just off the QEW, so it was pretty loud. They probably could not even imagine, 12 acres like we have at Huron Hospice, quiet, peaceful, lots of space to walk by the pond or on the trails in the 5-acre woodlot. And I wonder if they could also imagine the kind of connections we have in the rural area that happen when you're in a smaller community and people know each other. So I don't know that these happen in the same way in urban centers. So for us, this is terrific in terms of translating into donations, for example, of goods and services, from local businesses who have friends or family who may have used the services of Huron Hospice. So this includes everything from, window washing to pest control to the delivery of plants to us, Thanksgiving lunch for residents from a restaurant, feed that fills our bird feeders that the residents love so much, and so much more. So these are a couple of things that come to my mind that make hospice in a rural community a little different than it might be in an urban center.
Thank you. Uh, Now I'll pass one over to Stephanie. So, as the director of a local senior center, you act as a hub for connection and community activity, ranging from active living to wellness fairs and art clubs. What strategies are in place to support those who find it harder to get into the center, and what would make a difference for people moving forward to make that easier?
Thank you. It's a good question. I think one of the things that Dr. Erin pointed to was the communication and getting the information out about what's available and where is it available. The center here has been here for 45 years, and still people don't know where we are, and still people don't know what we do. So part of that is partnering with other associations, other groups, other stakeholders, doing educational information, doing presentations, trying to incorporate as much of the community as possible into inviting them into our space, and having different groups that use the space for different events or programs or information seminars. Support groups use our building as well. So again, trying to bring those in and just draw them to come and get some information and try and again make those connections with people, try and greet them when they come through the door. And again, like I had mentioned before, with our Links to Wellbeing program for those who are not able to come with the financial limitations, now we have an opportunity to provide them with a cab ride if they need to, or cover the cost of things like meals or taking part in the art workshops or anything like that.
Nice. It seems like you guys are doing a lot of work to make a welcoming space over there. I'll pass another question over to Erin, Dr. Erin. So this past October, Gateway looked at rural housing with the United Way and the rural mental health with the CMHA. These presentations acknowledge that there's a growing number of people who have lost access to housing and are experiencing poor mental health and addictions in the area. Your past research includes those who are unhoused and are experiencing mental illness, while the need for palliative care, with the need for palliative care. Has this project identified any key barriers in Huron-Perth for accessing services that these groups, and what might be actionable solutions? That's phrased a little funny, but I think they're generally looking for what solutions might there be for people looking for palliative care who are also facing housing needs.
That is such a big question, and it's a difficult question to answer coming out of this project, because this project wasn't really focused on investigating that. But I will share some reflections. I think one of the first and most important steps is increasing awareness that there are unhoused people with medical needs in our community. So I have heard that I've heard that we don't really have a homelessness problem, that that's really more of a Stratford issue. But then you talk to other service providers and they're saying, oh yeah, I'm definitely seeing these folks. They're out in the county, they're out in the bush, we're having interactions with them, even though other providers aren't having interactions with them. We know that the healthcare system really isn't built for it's you don't get home care when you don't have an address, right? Like you don't. And That can be a challenge. Other other cities I've lived in have started in the shelters, or they have started in the healthcare. Um, they have started in the healthcare sites that have created dedicated programming for people facing these challenges. And in Huron County, we don't really have that. We have the out of the cold shelter, but it's, that we could go into, but that program has really changed in the last couple of years. So I would think one of the first steps would be spreading the word amongst healthcare services and having individual healthcare services think about how they can help, and then reaching into the services who are really seeing these folks, and we're talking about the emergency room, and we're talking about 911 paramedics and community paramedics and police and CMHA, and starting there.
Thank you. I think that is really important to make those partnerships. And sort of on that note, we'll ask Stephanie, why are the partnerships between different not-for-profits and different organizations in the community so important for providing care and resources to people in the area, especially in rural areas? If anyone else wants to speak to it, they can as well.
That's the million-dollar question, right? We are stronger together. If we are all working at cross purposes, then we aren't providing the best care, the best information, and the best supports to our community. We have great partnerships within Goderich and Huron County. I'm impressed with how much we are all really able to work together to get information. And again, the more that we develop and that we can support one another in, then we have better opportunity to get our information out. And we had done a web series, not a web series, sorry, an in-person series with Huron Hospice with about, which actually was where I met Dr. Erin, about advanced care planning and, are your ducks in a row and getting the information out. And as people realized what the information was in the education sessions were about, the numbers kept growing and growing. And it was a great series. It was a lot of wonderful information. And we were actually able to do it again this year, albeit not out in Dungannon in our satellite location. So it's really, really important that we have the great supports amongst ourselves, the great shareholder and stakeholder networking contacts, because it is really important that if we're not communicating, we can't share our successes and we can't reach as many people as possible. And that's the most important thing. Being able to get the word out and letting people know what we have available to help them and support them as they age through their illnesses, through their health, through their wellness. And, if we can't communicate effectively and give them the information that they need when they're very vulnerable, then it makes it very difficult for everyone.
Thank you, Stephanie. I'll pass one over to Willy, which is on a similar note. Gateway hosted a conversation previously on predicting and planning end-of-life care, which Huron Hospice participated in. One of the key points that was made during that presentation and has been made during this presentation as well is that it's never too early to start a conversation, especially for those experiencing a life-limiting illness. Are there any local resources that Huron Hospice provides at different stages in the process? And could you explain sort of what that looks like for your organization?
Yeah, I'll just pick up from what Stephanie was saying. We've had this really good partnership and have done some speaking there about advanced care planning. One Care, I see Dawn Wildfong is here from One Care as well today. They've invited us to do a similar kind of series, and we're just beginning to now do some education there with their folks about advanced care planning. Our provincial association, Hospice Palliative Care Ontario, has also recently developed, they got some funding, and they've invited any hospices in the province to send volunteers to be trained in how to lead advanced care planning sessions. And that training is just happening right now. We have 3 of our volunteers from Huron Hospice in that training right now. Then they're going to go out into the community with this training and with these materials to be able to share this in other locations. So you'll be hearing more about that, and I expect that that'll be coming fairly soon. So that's a partial answer to your question, but it's really focused on this advanced care planning and just having people think about this ahead of time. I found myself on when my wife and I were on vacation in the summertime, I took the booklet and kind of we worked through it ourselves, right, to sort of see what that might mean. And there's another one that's been developed by the hospice, one that's not known so well, way up on the Bruce Peninsula. They've done a really nice one that's really, really practical and really well done as well.
That's great to hear. And those might be resources for people who are looking for sort of that guide on what to do afterwards as well. So if you were people in the chat looking for that, that might be somewhere to look on the hospice website. I have 2 more questions. Oh, never mind. I've got one coming in the question chat. So I'll give one to Erin and then I'll come back to this one. So this has been a great project to hear about, and thank you for sharing your findings. I noticed that community members, specifically patients and families, weren't included in your project. Could you talk about that?
Yeah, so this started off as just a quick and dirty little thing I was going to do over the summer that was going to take me 1 to 2 months. Doing consultation right with patients and families takes time. It takes investment. And if you're asking time from patients and families, you really want to be able to give something in return. I didn't know yet what was going to come out of this project in terms of priorities. It is possible that what I would be able to do in the short term would not be of direct visible benefit to patients and families. And I hesitated. I worried about my ability to then go back to patients and families when I had more focused questions in the future if I couldn't demonstrate a return now. Also, as a relatively new researcher without a senior researcher on my team and without an ethics body to review my project, I wanted to be cautious about how I worked with patients and families to make sure that I wouldn't inadvertently do harm. I want to engage more with patients and families in the future. I think that's the right way to move forward when you do these grassroots projects, when you are dedicated to doing projects that are informed by the communities you're working in. I need a little bit more time to do that right.
Thank you, Erin. And then I have one last question in the chat, which I think is kind of targeted at all of you. There are some excellent examples of barrier-free access, such as no need for a health card, no intake, no forms, no appointments, no referrals, at the Community Paramedic Knowledge Exchange in London in September, and that have been shared here today. Thank you for that. Is there an opportunity to formalize an intersectional community of practice in the area to target access for barriers of population exposed to conditions that predispose vulnerability? Are there any plans to create a resource? So I think, what does that intersectionality look like for all three of you? You work together across the county, and so are there any plans moving forward for that intersectional work?
Hold on a sec. I need to read this question.
Yeah, it's in the Q&A box if you guys want to give it a quick read.
Yeah. There are definitely things happening. There are definitely great things happening in some of the regions around us, and I'm excited to see that. This project was focused on Huron and Perth. In some ways, we have a little bit of catching up to do. I would love to be more engaged in communities of practice on a regional level and some of these programs on a regional level. I believe that in order to do that effectively, we need a stronger coalition um, with operationalized organizational relationships, which we don't have as many of right now, at least not related to a palliative approach, which is one of the reasons that I felt so driven to do this project. Um, I look forward to that. I look forward to that in the near future. I look forward to being able um, to to join in on some of these. I think that's a great idea.
Okay, and that is the end of the questions that I have on my end. So if anybody has anything else, I'll give you a couple of seconds to put it in the question and answer box before we wrap up for today. I can see when people are typing and I don't see any typing. So if a question comes up, you can interrupt me, but until then, I will just do the closing remarks. So we would like to, first of all, thank our presenters for presenting today. And then we would also like to thank a few of the sponsors who support our lecture series for their continued support: CIBC Wealth Management, DeJager Town Square IDA Pharmacy, Hurontel, the Libro Credit Union, Lighthouse Money Management, McEwen and Fagan Insurance, and the Zehrs Goderich. Gateway CERH is a not-for-profit organization with charitable status, and we greatly appreciate and welcome any support that we receive. We will be continuing the conversation on December 2nd with Dr. Tejal Patel from the University of Waterloo, joined by Kristen Watt, a pharmacist, and Sarah Milner, the Executive Director at Central Lambton Family Health Team. on taking charge of your medication, what you need to know, and the tools that can help you. So thank you to all of our panelists, our sponsors, and especially to you for tuning in today. It's been a great conversation, and we look forward to seeing you next month.
Hey, Ava, before we jump out, I know we directed people to the Huron Hospice webpage.
Yes,
Can we put that link in the chat, please?
I can grab that.
Thank you kindly.
No problem. Oh. There we go. I will put that. Oh, I can only send to the host and panelists. Jay might have to send it into the main chat. I can put it in the Q and
Yeah,
no, I
I've
can't.
got that, Ava.
Jay's got that. Okay, thank you.
Thank you, Jay.
Perfect.
It's also pretty simple, huronhospice.ca.
Great. Thank you kindly. All right. Thank you, everyone, for coming. My email is on the Gateway webpage if you would like to reach out and connect.
Thank you. Jay has the power to end the call whenever.
Okay. Thank you, everyone, for joining. And
Okay.
we will see you next time in December.
Perfect.